Today we're setting up our first presenter who's going to talk about HypoPARA 101 to make sure we've got grounded in our basics. We know that every time we hear something, we may hear it a couple different times throughout the next couple of days, but you may hear it a little differently and it'll connect with you. So we're excited to have Dr. Mark Warren with us this morning from Greenville, North Carolina. Welcome aboard, Dr. Warren.
All right, good morning. So I get to set the stage for the rest of the conference. And so what is a 101 course? It's introduction. A lot of you are probably at the graduate level. It doesn't hurt to hear it again, and maybe you'll hear it several times this weekend. So we're going to discuss several things. All right, advance the slides. Advance the slides, please. Didn't seem to go. There we go. So we're going to talk about several things. We're going to set the stage again for the weekend. Let's get the definition of HypoPARA, what's acute, what's considered chronic, what are the causes. We'll look at both the normal and the abnormal parathyroid physiology, the signs and the symptoms of HypoPARA, some of the risk factors for post-surgical HypoPARA. How do we monitor HypoPARA? What are some of the complications? We'll look at the conventional therapy. We'll talk about that. And we'll look at some of the unmet needs. So let's start with the definition. HypoPARA is a rare endocrine disease. It results in either absent or inappropriately low concentration of parathyroid hormone in the setting of low calcium or hypocalcemia. Now, this is probably 8-year-old data now as far as a prevalence of 77,115 in the U.S. It's probably much more than that, so Dr. Manstat, we probably need to update this study. It's probably close to 150,000 at this point in the U.S. And anterior neck surgery is the most common cause of HypoPARA. So etiology is a fancy medical term for causes. Post-surgical is 78% of it. Other secondary things like you can have radiation therapy, you can have other things that you can have metastatic cancer, other things can damage the parathyroid glands. There's familial, about 7%. And idiopathic is another fancy medical term for we don't know, or I like to say we're not smart enough to figure out yet. So that's what, most of it, 78% of it is post-surgical. There are looking at some of the genetic causes, there's disorders of parathyroid formation. The most common is the George and Charge syndrome, but there's at least 15 others, and I couldn't possibly list them all and get through the lecture in time if I did that. So there's at least 15 others. There's also destruction of the parathyroid glands, autoimmune disorders, and polyglandular syndromes. And there are disorders of parathyroid secretion, such as autosomal dominant hypocalcemia type 1 and 2. We'll hear about that later on today. And you can also have an autoimmune syndrome where the antibody activates the calcium sensing receptor. There's familial dominant hypopara and hypomagnesemia syndrome, Gittleman syndrome, and many, many, many others. So I was going to put a slide with all of them up there. I couldn't even possibly see the letters, so I couldn't do them all. But just as you know, there are many other causes of hypoparathyroidism genetically. Okay, so let's look at the normal function of parathyroid hormone. In response to a lower calcium, the parathyroid hormones, which are parathyroid glands, which are 4 little glands at the behind the thyroid. They're about the size of a grain of rice, and they secrete parathyroid hormone. And so in response to low calcium, it activates, has several actions. One, it works on the bone to cause bone resorption, to release calcium from the bones. The bones are storehouses of calcium. And it also works on the kidney it helps with the calcium resorption. When the kidneys, they're filters, so they filter the blood, and calcium comes out very easily. And if you don't reabsorb it from the tubules, you'll end up with excess calcium in the urine. And it also helps with phosphorus excretion. And in the kidneys, it helps regulate the activation of vitamin D from 25-hydroxy to the dihydroxy, 125-dihydroxy vitamin D. And that acts to cause calcium absorption in the gut. So by increasing the calcium reabsorption in the kidneys, help the calcium absorption in the gut, and help with bone reabsorption and releasing calcium, it causes an increased calcium, and that in turn feeds back to the calcium sensing receptor, and then that regulates the parathyroid hormone release. So there's always this feedback mechanism. It's important to keep calcium in a good range because calcium is important for a lot of things, muscle, and, muscle function, nerve function, etc. So in the absence of parathyroid hormone, you don't have that calcium reabsorption. You end up having too much calcium in the urine, which can cause kidney stones and calcification of the kidneys. It also increases the phosphorus reabsorption, so you end up could have increased phosphorus levels. And because you're not activating the vitamin D, you have a decreased calcium absorption, and you're not absorbing calcium from the bone, there's not resorption from the bone. All this leads to a decreased calcium and the problems thereof. So let's look at how do you identify, diagnose, treating, and monitoring hypopara. Well, these are the symptoms. Signs are things we measure, and symptoms are things you feel in medical parlance. The severity can be from no symptoms at all to very severe, and it really depends on how quickly it got there, how severe the calcium is, how low it is, and the chronicity. So you could have, if it's chronic and you've developed it slowly over time, you may have no symptoms despite a very low calcium. I've seen people come in with calcium of 6.5, presenting with just cardiac failure. Their heart wasn't functioning very well, but they had no symptoms of paresthesias. And once we corrected it, their heart function went back to normal. That spoke to chronicity. But if you had it immediately after surgery, it happens very quickly, and you can have very low calcium levels. So that can lead to more severe things like heart arrhythmias and laryngospasm, where you can't feel like you can't breathe because your throat's closing up. And you can have seizures as well with very low calcium. But most of the symptoms we have are paresthesias, muscle cramps. Those are the things we have. We'll talk about some of the other symptoms in a moment. So who's at risk for developing post-surgical hypopara? Well, if you happen to have low preoperative levels of vitamin D and calcium, that's a problem. And you also, if you have a low intraoperative parathyroid hormone level, sometimes they'll measure that after parathyroidectomy or thyroidectomy. And then we used to do a lot of parathyroid autotransplantation, hoping that the gland that's transplanted would start working. That turned out not to work very well, so we don't recommend that anymore. And if you have to have reoperation for your thyroid for bleeding, that can be a problem or a risk factor. And if you have pre-existing Graves' disease and failure to identify at least 2 parathyroid glands during surgery, and if you happen to have PTH levels less than 10, 12 to 24 hours after surgery, again, reoperation for bleeding or heavier thyroid specimens, for example, if they're trying to be a very aggressive surgery for large thyroid cancer or a complicated thyroid cancer. So those are risk factors for developing post-surgical hypopara. So how do we define transient versus chronic? These are the newest guidelines. So transient is defined as less than 12 months, and chronic is defined as lasting more than 12 months. Now, you can also have intermittent hypopara, where you have sort of a partial parathyroid deficiency, where you feel fine until you do something, perhaps overdo something physically, and you have symptoms. And also, post-surgical hypopara may resolve within days, weeks, months. Usually about 12 months it would have resolved if it's going to, but sometimes we even have it resolve even beyond the 12 months. But the current guidelines recommendations are for the chronic is defined as greater than 12 months. Our conventional therapy is to start with calcium carbonate or calcium citrate plus active vitamin D analog, and we titrate or we adjust those doses to maintain the calcium in the lower half of normal, lower half of the normal range, or just below the normal range. Well, I like to keep it between 8 and 8.5. Normal range usually 8.4 to 10.5. We adjust the vitamin D otherwise to keep the 25-hydroxyvitamin D in a normal range. And additional therapy might be needed if you have excessive calcium in the urine, we call hypercalciuria, or if you're having problems with elevated phosphate levels. So these are the medications we currently have. So calcium carbonate or calcium citrate, that's available, over the counter, of course. Calcium carbonate is the most common one. Calcium citrate has less calcium per pill. You have to take more of it, but it's less constipating. The range is anywhere from 500 to 3,000 milligrams per day, given 3 times daily with meals, because it enhances absorption. But certainly I've seen folks needing 12 grams a day in more severe cases. That's a lot of pills, and a lot of you know what I'm talking about. And then we'd like to supplement with some vitamin D, 1,000 units a day, usually 1,000 to 2,000 is what I recommend, and maintain a normal 25-hydroxyvitamin D level. We can also use ergocalciferol, which is a prescription strength vitamin D, 50,000 units weekly, if necessary. We actually used to use that before we had less expensive calcitriol to treat, but we don't recommend that as a way to monitor or to adjust the calcium levels, because it's long-acting. You can get long-term toxicity from it if you were to get toxic from it. Calcitriol is the active vitamin D, and that's what we typically use to help maintain a normal calcium level. And it can be given 0.25 micrograms to 3 micrograms a day. Again, we adjust it based on the calcium level. Alpha-calcidol is used not in the U.S., so it's mostly European and other countries. So that's not a U.S. medication. And then thiazide diuretics are used to control hypercalciuria, or the calcium in your urine. We monitor you looking at the calcium and magnesium, phosphorus. We do that every 3 to 12 months, depending on how stable someone is. Once they're stable, every 6 months is fine. But if they're not stable, we may have to come even more frequently. We'll check their creatinine or kidney function. We'll look at their vitamin D every 6 to 12 months. And we'll do 24-hour urines as necessary, around anywhere from 6 months to every 24 months, depending on how they're doing. If they've had a normal one, we probably go at 24 months. Ultrasounds of the kidneys to look at nephrocalcinosis, which is calcium in the kidneys, and kidney stones can be done after you've had it after hypoparathyroid's you've had it for a couple years maybe, or if you're having uncontrolled hypercalciuria or too much calcium in the urine. And patients with visual symptoms may need to see their eye doctor to look for cataracts, et cetera. But it's also look at not just their numbers, but the physical functioning and well-being, because over 40% of folks with HypoPARA report interferences with work productivity that they attribute to either physical or cognitive symptoms experienced with HypoPARA. And 33%, or a good third of them, reported no longer being able to work due to their hypoparathyroid symptoms. And 60% of the participants reported they're less physically active than they used to be. And I think that as a clinician, it's important to ask beyond what the levels are, look beyond that and ask how they're doing through these other symptoms and beyond just the numbers. So what are the complications and then some of the problems with conventional therapy? Well, it can affect basically every system. We're going to have a lecture dealing with all of this, specifically about the complications of hypoparathyroidism. But we'll look at a few of these, but we'll look at kidney and we'll look at CNS and the cardiovascular system as well. I'll say in the dental, it's not an issue unless you had it during your formative years as a genetic hypopara. So let's look at the renal complications. Up to 40% of patients who had nephrocalcinosis. These are people who had it for a while, and 36% had kidney stones. But again, these are folks that probably have had it for several years. And there was about a 3 times risk of developing chronic kidney disease and about 1.6 times risk of progression to a higher chronic kidney disease stage, and a 2-fold risk of progression to end-stage kidney disease requiring dialysis. So once you have it, there's a higher risk for it progressing. As far as cardiovascular complications, There is a higher risk of what we call arrhythmias, which atrial fibrillation, for example, is a very common one. There's also a higher risk of having cardiovascular disease like coronary disease, myocardial infarctions, strokes, and peripheral vascular disease. So there's a higher risk of that as well. As far as the CNS complications, so the central nervous system, that's a fairly broad subject, but here's a patient says, I just don't think clearly anymore. I just don't feel smart. That causes an onset of anxiety and depression. It just wears you down. That probably sounds familiar to a lot of you. So hypocalcemia and low parathyroid hormone levels have been suggested as factors that may induce central nervous system disturbances. It's been estimated at least half of folks with post-surgical hypopara exhibit psychiatric symptoms, and folks with hypopara have a higher incidence of depression and bipolar affective disorders compared to the general population. And folks with hypopara have significantly more cognitive effects, reduced inhibitory control, psychomotor retardation, which means you're not moving as well, and compared to control populations. There are still some unmet needs in hypoparathyroidism. 72% of patients experienced more than 10 symptoms in the last year despite management regimens. And 79% of patients required hospital stays or emergency department visits due to hypopara. 75% of patients felt concerned about their long-term complications of their current medications or for managing hypopara. So there's a lot of concern. And 67% of them required multiple medication regimens with calcium and active vitamin D. So it's a significant burden of illness. And 34% of patients required taking at least 6 or more blood tests over a 12-month period to check their serum calcium. And they saw their physicians at least on average around 4 to 5 times per year. So there is a significant burden of illness of having to take pills, getting your blood tests, and seeing your provider more frequently than you otherwise would need to. So even with normal calcium levels, or the best thing, getting our calcium level where we want, people still don't feel well in general. In fact, look at the big blue there, the big blue piece of the pie. 48% of patients did not feel well despite having recommended serum calcium. Despite this, they had low well-being. In fact, only 22% of folks had the recommended serum calcium and had a high well-being. So we're missing the mark 4 out of 5 times. Only 1 in 5 patients has the recommended calcium level and feel well. We also know there's an impaired quality of life. There is a questionnaire called the SF-36. This is a questionnaire with 36 questions, and it has domains of physical functioning, bodily pain, general health, social functioning, emotional health, and mental health. And you want, like on most tests at school, you want to score high here. So you have no impairment, you put 100. If you have severe impairment, you put 0. So in the light gray are the normal controls, and in the darker line is folks with hypopara. As you can see on every domain, they score lower. So there is an impairment in the physical, the bodily pain. You can see really in that role physical, that second one, they're much lower than normals, than their comparators. And social function is impaired, mental health is impaired. In fact, one patient said, I just get worn out quicker and my muscles start hurting and they're sore. So there's a quality of life issue, and hopefully if we, with better therapy, we'll be able to address the quality of life. So conventional therapies fail to restore normal parathyroid physiology. Currently addresses just the serum calcium. Doesn't address the active vitamin D formation in the kidney, the poor absorption of the calcium from the intestines, the calcium reabsorption issue in the kidneys, and the calcium resorption in the bone, and it doesn't do anything to address the quality of life. So what are the indications that the hypoparathyroidism may not be fully managed? Well, if you're having problems with hypocalcemia despite taking the conventional therapy, despite using 2 grams a day of calcium or more, 2 micrograms with the active vitamin D, or if you're having intercurrent problems, you're getting hypocalcemia symptoms and issues with malabsorption, that could be an issue. If you're having hyperphosphatemia despite the therapy you have, it could be affecting the calcium deposition or deposit of calcium in the brain and the blood vessels in the kidneys, or if you have kidney insufficiency with reduced what we call EGFR or glomerular filtration rate, or if you're having problems with hypercalciuria, because this may increase your risk of developing kidney stones and calcium deposits in the kidney, and finally, poor quality of life. And this is where you have it has negative impacts on relationship, employment, and daily activity and mental health. And why that's important is that the other ones are those are things we can measure. Quality of life is something that you're telling us about. And I think insurers typically use guidelines to decide how to pay for medications. So I think now we have some guidelines here that determine when your calcium may not, your hypoparathyroidism may not be fully managed. So these may be used, we don't know yet, but by the insurers to determine if you would be an appropriate candidate for expensive medications. So some of the unsolved problems, HypoPARA is the only classical endocrine deficiency without a currently available hormone replacement therapy, only one. Now hopefully in a couple months, this will no longer be the case, but right now that is the case. And I find that's most incredible. And even if a patient's on calcium and vitamin D, symptomatic hypocalcemia or hypercalcemia occur in the setting of acute illness, dehydration, or stress. And some patients with HypoPARA have disease that is refractory to conventional therapy. Even with close monitoring, patients can continue to have elevated phosphorus levels and hypercalciuria. And we can still have problems with reduced physical functioning and well-being. So to summarize, HypoPARA is an endocrine disease that can impact every organ, essentially. Understanding the diagnosis and symptoms of HypoPARA can help us to improve the quality of life and long-term disease outcomes. Conventional therapy does not address parathyroid hormone deficiency, may increase the risk of long-term complications. The burden of chronic HypoPARA negatively impacts the physical functioning, well-being, irrespective of serum calcium levels, and providing biochemical control, high quality of life, and to minimize the potential risk of long-term complication remains a challenge today. And I'll leave you with this. One of my medical students rotating through asked me why I was so excited to participate in the clinical trials of HypoPARA, and I said, you know, being thanked for finally getting their life back never gets old. Thank you.
All right. Thank you, Dr. Warren. That was wonderful. We're going to take some question and answers from the room, and we have a bunch online. Anybody in the room have a question for Dr. Warren? And we have Katie has a microphone, and Bob has a microphone. Is there anybody in the room that has a question? All right.
Hello, doctor. In one of your slides, you were explaining, right over here. In one of your slides, you were showing some ancillary symptoms that might come along with this disease, and it mentioned seizures as a potentiality. Seizures, as I understand them, is an issue of the brain that is affected physically. Is there some difference to what seizures are when it comes to this issue?
All right, so some people have a predilection to having seizures anyway. So having a low calcium lowers your seizure threshold, we call that. And sometimes if you don't have a predilection for seizures, just having a severely low calcium will cause a seizure because the neurons start firing on their own. So you can have that just from a very low calcium. And I've seen that, unfortunately, several times.
Okay. Over here?
Thank you. Doctor, could you explain maybe a little bit more in detail the effects of calcium on the cardiovascular system, just the pathophysiology of that?
The effects of calcium in the cardiovascular system. Well, so You have to have calcium for normal muscle functioning. It's involved in the contraction of the muscle. And so the heart's a very big muscle, and it requires calcium. And if you don't have enough calcium, you're going to not have proper contractility of the heart, so it's just not going to work as well. And it also affects the electrical system of the heart. So, so that's where you have some of the arrhythmias. And then it can also cause issues with depositing calcium in blood vessels, causing issues as well. And sometimes that's when your phosphorus and calcium levels, your phosphorus is high and your calcium, what we call calcium phosphorus product, is too high. So we'd like to keep that phosphorus in normal range.
Okay, Michelle?
Yeah, we have one online that's related to that question, and it says, how would I know if it's affecting my heart? Is there a test I should be getting?
There's nothing specifically that we recommend for screening purposes other than what you would ordinarily do for just regular health. So there's really no issues unless you're feeling as your pulse is irregular or abnormal, then get checked out. But there's nothing preemptively you need to do.
Unless you're having a symptom.
Yes,
of the heart
unless you're
fluttering,
having
right?
symptoms.
Okay, question over here.
Dr. Warren, is having coronary vasospasms, is that a normal symptom to be having?
You can have that because, again, the calcium levels are low and there's muscles in the vasculature, and it can cause vasospasm as well, or spasm of the blood vessel. Fortunately, it's not very common.
We have a question in the back. Bob?
Hey, I just had a question. I saw a thing about ocular complications. I was just asking about the symptoms that comes with hypoparathyroidism patients.
It's mostly cataract formation. Can be more common.
Michelle, anything else online?
Yes. Are there any specific recommendations for increasing your calcium supplementation when being more active than usual?
Well, that's a tough question. And basically, folks that are become more physically active, typically their calcium levels get a little lower, and you require a little bit more calcium supplementation. That's going to be a little trial and error, taking a little more calcium than usual.
Next, they ask, does consuming caffeine affect my calcium absorption?
Not that I'm aware.
Hi, that was fantastic. I always learn something. Can you say something about calcium safety and what you recommend to your patients when they're worried about a calcium crisis?
If they're worried about calcium crisis, obviously contact your provider ASAP, but in the meantime, what can you do about it? The problem is the symptoms may not be very specific, right? So you start worrying about it, you get anxious. The symptoms are very similar to having a low calcium. So that's part of the issues with cognitive issues, you get anxious. So there's a lot more anxiety with this condition. So I think that's really talking with your provider and discussing how often this is happening, and perhaps getting a little more calcium, more frequently calcium tests to show that you're having a stable level. And I think if you're having some issues, discuss with maybe taking an extracalcitrol and extracalcium would be reasonable. But again, most of those symptoms are probably anxiety related and not related to a lower calcium. It's hard to know, isn't it? It's really, it depends on the person, and I think that's a discussion with the provider and making sure their calcium levels have been relatively stable.
Bob?
So I noticed on the form that the Parkinson-like disease symptoms can be part of this. Can you explain what those symptoms would kind of look like?
So Parkinsonism occurs more commonly in hypopara, especially those who have had issues with higher phosphorus levels and having hypoglycemia for many, many years, because you get calcium deposition in what we call the basal ganglia. It's part of the brain that's involved in Parkinson's. Often these symptoms get better if you correct the hypocalcemia. So Parkinson's the syndrome is, you're having slower gait, you're moving slower, you're having tremors, and those are the symptoms of Parkinson's. And we're going to have a lecture about Dr. Schoback later about complications. I think she'll deal with that a little bit more.
One more, Bob?
Yes, I'm hearing, because I'm still learning about being hypopara, but there's always sort of like a debate between citrate and carbonate. Some people say take the carbonate because carbonate binds with phosphorus, which keeps it better in range. So I'm just wondering your opinion or your expertise, like which one is really better to take, the citrate or the carbonate?
The calcium carbonate is a better phosphorus binder, but they both can bind phosphorus. I prefer calcium, I prefer not doing calcium citrate because you're having to take so many. But if you're having issue with calcium carbonate with constipation, you can always take calcium citrate, but you got to take about twice as many pills. So if you're already taking, 6 pills of 500 milligrams of calcium carbonate, then you're going to have to take 13, 14 pills of calcium citrate, and I think that gets to be more cumbersome. It's really up to the person.
Okay, Bob?
Hi, you had mentioned the SF-36 Quality of Life Survey. In preparation for Yorvipath coming on the market and people needing to argue with their insurance companies, are there any other medically accepted quality of life, mental health, cognitive surveys we should look at completing with our endocrinologists ahead of time to support getting the medication approved?
Oh, that's a good question. I think you're better off not having it because if you have something, they're going to hold you to it. So I think more of a discussion of quality of life, how they're feeling, and it's really having that in the medical records. I don't think SF-36 is is really for clinical trial purposes. But I think if you had that, they may help direct the questions from the provider. So it's something you could certainly develop, and there are some specific surveys of hypoparathyroidism and quality of life there you could use as well. But in a busy practice, it'd be hard to really give that survey and involve the provider. But that's something we can certainly discuss and talk about. It's intriguing.
Okay, Michelle?
Yes, I have one that says, does HypoPARA affect our immune system?
I don't know the answer to that question. I suspect it does, but I don't have any specific evidence for that.
Okay. And you mentioned calcifications of the kidney. If we have those, is there any way they can be reversed?
And once it happens, it's hard to reverse it. You can slow it down. To my knowledge, there's no way to reverse it.
And another person online asks, can it affect our liver?
Not to my knowledge. We can ask Dr. Schoback.
Marisol?
Hi, my question is about treatment. Would you recommend using calcitriol at the same time of high doses of vitamin D, like 15,000 units?
Well, I think that I used to use high doses of vitamin D to treat folks with hypoparathyroidism. That's before calcitriol was generic and the other was very expensive. So we no longer do that because the calcitriol is shorter acting. It's quicker to get your calcium levels up, and if you're having problems you overtreat, it's quicker for it to go away. So I don't recommend using just the vitamin D as your primary therapy. So I recommend 1,000 to 2,000 units of vitamin. It just depends on what your vitamin D level is in the blood. That's what I would monitor.
In instances where your hypocalcemia requires an ER visit, are there helpful tips and tricks to work with doctors who aren't experienced in this rare disease so that they skip some of the more common checks of things firsthand and get to the immediate issue?
I'm sure you've had a lot of your people have these experiences, I think. I think grab him by the tie or her by the coat and say, I have hypocalcemia, I'm in crisis, check my calcium, give me some IV calcium right away, please. I think you have to be very proactive. Said, I know what my issue is, I've had it before, I have hypocalcemia, please, I'm really having a crisis here. And I think that if you can go ahead and get some calcium ordered and while the calcium level's cooking, I think that's, you just have to be really proactive, let them know you know what you're talking about, you've done this before, and so it may be helpful.
And hopefully it'll get through. And you have your emergency cards that are in your bags that you got. Carry those everywhere. Keep them in your car, keep them in your purse, keep them in your pocket. Do they work? Sometimes they work, sometimes they don't, but have every piece of something that you can have to help calmly explain to the doctors after we grab them by the coats to say, help me, give me calcium. So Bob?
Good morning. My question is life expectancy. I remember at one point they had no idea what our life expectancy was. And I'm just wondering now that there have been some biological drugs, like there was HypoPARA for a while, now there's other ones. Is that affecting anything? Or have you looked at people when insulin came around, which I realize is over 100 years ago, but how getting that changed their life expectancy, or if there might be any correlation? Or we still know nothing?
I don't know of any studies of life expectancy or decreased life expectancy with HypoPARA, but of course, if you're having chronic kidney issues, that increases your risk of cardiovascular disease, and also if you have HypoPARA, you have a higher risk of cardiovascular disease as well. So I suspect it affects it, but I just don't know to what degree. I think managing the issues, and knowing what the issues are, managing the HypoPARA and the hypocalcemia effectively and not overtreating, will help that, but I don't know any data looking at long-term outcomes with longevity.
Okay, and I'm going to ask your final question. You got one more?
One more.
This may be the first we can't answer that question. So I'm curious, because you've done all the trials for all the different HypoPARA drugs that are going on. In your experience, have you noticed a difference in kind of the levels versus symptoms? Can people tend to be at a little bit lower level and be okay and not have symptoms, where before they had to be at a higher level? Any kind of experience that you could share?
I don't know that I've seen that. I think that when they get to the, usually in the blinded section, we know who's on placebo because their calcium and calcitriol requirements didn't really change. But in the open label, for sure, we know. And people just feel so much better that I just don't get many complaints. They're just happy to be normal.
Yeah, because we're treating the hormone.
Yeah.
Yeah, very good.
Thank you.
Well, let's give it up for Dr. Warren. Thank you so much. Thank you so much.